Hi friends, let's talk about upper limb fractures and some name fractures which are very important. Every exam will always have questions from it. Bankart in 1938 described the anterior tier of the glenoid labrum as the Bankart's lesion. Bankart's lesion is one of the very common lesions associated with recurrent shoulder dislocation, which is the commonest complication of a shoulder dislocation in a young patient. Shoulder, most common joint dislocated in human body, usually dislocates anteriorly. And remember, Bankart's is an anterior tier of glenoid labrum. It's anterior, it's not anteroinferior. And the corresponding bony fracture of the same area is called as the Bankart's fracture. Bankart's lesion involves the glenoid, and similarly its counterpart, the HILL-SACHS lesion, involves the posterolateral aspect of the head with a depression on this area seen in anterior shoulder dislocation. I also want you to remember a mnemonic here called as RAMP, which refers to reverse HILL-SACHS, anteromedial part, posterior shoulder dislocation. So in anterior dislocation, you have posterolateral shoulder affected, and posterior dislocation, anteromedial part affected. Remember H for HILL-SACHS, H for humeral head. When we look at the entire shaft of humerus, if we divide it into three parts, upper 1/3, that's the area from which the radial nerve grows from the axilla till the humerus. The middle 1/3, where the radial nerve traverses in the spiral groove, and the lower 1/3, where it pierces the lateral intermuscular septum and comes anteriorly. The question very commonly asked is, out of upper 1/3, middle 1/3 and lower 1/3 fractures of the shaft humerus, where is the radial nerve most commonly involved? The common thought is it's involved in the middle 1/3, where it's close to the spiral groove. But actually, if we look at the incidence, it has got the maximum in the lower 1/3, because here the radial nerve becomes fixed. And that's the rule of thumb. Whatever becomes fixed becomes rigid and is more prone to get damaged. For example, the medial meniscus is fixed to the underlying capsule and it's more commonly damaged as compared to lateral meniscus in the knee joint. I also want you to remember one point here, that the radial nerve in the lower part of the arm divides into two branches. One, the posterior introitious nerve. Second, the superficial radial nerve. The posterior introitious nerve is a pure motor nerve that takes a turn around the head of radius. The question that is also asked is, the fractures of lower 1/3 of humerus, they entrap the radial nerve. What is it called? They are called as the HOLSTEIN-LEWIS fracture. Ames, May 2016, an image of spiral fracture of lower 1/3 of humerus was asked, and the question was asked, what nerve is involved? And the answer was radial nerve. Two more things that you must remember about radial nerve. This is the most common nerve damaged in human body, and it has the best prognosis amongst all the peripheral nerve injuries. The next injury that we talk about is the Galeazzi fracture. Galeazzi is 3 times more common than the Monteggia, its counterpart. Galeazzi fracture consists of 4 parts. Number 1, fracture of the lower part of radius. Number 2, dislocation of the distal radioulnar joint. Number 3, there is damage to the interosseous membrane. Number 4, there is damage to the triangular fibrocartilage complex at the ridge joint. Thus, Galeazzi, which was asked in Ames May 2017, the question was, what are the components? Number 1, radius fracture. Number 2, damage to distal radial joint. Number 3, interosseous membrane damage. Number 4, triangular fibrocartilage complex damage. All 4 were given, had to be marked together. Its counterpart, Monteggia, is a very common image. Monteggia is a fracture of the medial bone, that's the ulna, towards mouth, that's the upper 1/3. It's called as Monteggia. So MMM, medial bone towards mouth, is Monteggia. But what is more precious? More precious is there is a dislocation of the radial head, and that, although appears to be a minor component, but is more important because around the head of radius the posterior interosseous nerve travels, and this is very common nerve involved in injuries in Monteggia. Monteggia was classified by Bedo into 4 types. Bedo classified Monteggia into 4 types according to the area where the radial head dislocated. If the radial head went anterior, it was Monteggia type 1. If the radial head went posterior, it was Monteggia type 2. If the radial head went lateral, it was Monteggia type 3. And if there was a fracture of both the bones involved with the dislocation of the radial head, it was Monteggia type 4. This is the Bedo's classification. Type 1, where the head goes anterior, is the most common, and that was the question which was asked in Andhra PG 2016, where the answer was Bedo's type 1. They did not ask you what this fracture is, they asked you which type of Monteggia it was. Going to Hume fracture. Hume described an injury in children where there was a fracture of the olecranon. Along with that, there was a dislocation of the radial head. So it was basically a fracture of ulna, proximal part of ulna, the olecranon area, with the dislocation of radial head. This is common in children, and this is called as a variant of Monteggia. Similar injury, nearby but not exact, Hume fractures. Then one more forearm injury is Essex-Lopresti injury. In Essex-Lopresti injury, there is a component at the elbow and there is a component at the wrist. The component is connected from the elbow through the wrist by the damage involving the interosseous membrane. There is a fracture of the radial head with dislocation of the distal radial joint because of disruption of interosseous membrane. Question asked, Essex-Lopresti injury involves radial head, interosseous membrane, distal radial joint. If you have to choose one, the better answer is interosseous membrane, which explains the mechanism of Essex-Lopresti fractures. One Moore's fracture, not very commonly asked, is a rare thing, is a fracture of distal end radius with dislocation of the ulnar styloid, ulnar lower end, with entrapment of the ulnar styloid under the annular ligament. Distal radius fracture with ulnar dislocation and entrapment under the annular ligament, Moore's injury. Nightstick fractures are isolated fractures of the ulna, occurs due to direct blow without involving damage to any other component in the forearm, the elbow, or the wrist. Nightstick is just a transverse fracture or an oblique fracture of the ulna directly because of direct injury. Greenstick fracture. Greenstick fracture occurs in children. This is an injury where one of the cortices breaks and the other cortex bends. This is seen in children, a common pediatric injury. Now we come to the injuries around the wrist. Colles and Smith, they are opposite of each other. Before I talk to you about this, what I want to tell you, when I look at the AP view of the wrist, when I look at the AP view of the wrist, that's how it looks like. In the AP view of the wrist, the bigger bone is the radius. On the radius, we have a boat-like bone, that is the scaphoid, and just on the medial aspect of it, we have the lunate. So we have the scaphoid and we have the lunate. That's how the AP view of the wrist looks like. But when we look at the lateral view of the wrist, when we look at the lateral view of the wrist, that's how the lateral view looks like. And in the lateral view, the first metacarpal, that's the thumb, is always anterior, also called as volar, and opposite to it is called as dorsal. For example, if you look at this lateral view, this is the first metacarpal, so anterior. The opposite is dorsal. So what actually is the Colles fracture? Colles is an extra-articular fracture of the distal end of radius, classically seen in osteoporotic females, due to fall on the outstretched hand, causing displacement posteriorly. That's how we remember it. PC, P, Priyanka Chopra, right? Posterior is Colles. So extra-articular fracture that goes posteriorly is Colles. Opposite of it, extra-articular fracture means away from the joint. Going anteriorly, this is the first metacarpal. So that's the anterior aspect. Going anteriorly is Smith. Colles fracture leads to the dinner fork or the bayonet deformity. But remember, the most common complication of a Colles fracture is stiffness of the fingers, whereas the Smith fracture leads to the deformity called as garden spade deformity. So Colles, dinner fork deformity; Smith, garden spade deformity. Going further, if we look at the fractures of the radius, which are intra-articular. Intra-articular means through the joint. That's how we have just learned. This is the AP view showing the radius, the scaphoid, lunate. In NEET 2016, they were showing arrows on lunate and they had asked you to identify. So this is radius, this is the scaphoid, that's the lunate. And what I want to tell you, on the lateral view, you can see that this is anterior because of the first metacarpal being anterior or the volar, and the opposite side is dorsal. So what actually is Barton fracture? Barton is an injury involving the joint. It's going to the joint with the wrist dislocation. If the wrist goes anteriorly, it's called as volar. If the wrist goes posteriorly, it's called as dorsal. And one important thing is, volar Barton or anterior Barton dislocation is far more common as compared to the posterior. Coming to one of the top-notch questions asked in image-based exams, called as the Chauffer's fracture. If I look at the lower end of radius, that's how it is. And this is a fracture of the radial styloid involving the articular process. Now this articular fragment is very precious because this becomes an intra-articular fracture. Chauffer's fracture is intra-articular fracture involving the lower end radius of the radial styloid. There's one more thing that I want to tell you here is, if I look at the scaphoid here, scaphoid is a boat-shaped bone. It has got two ends. One is the distal end and the other towards the lunate is the proximal end. The blood supply of the scaphoid comes from distal to proximal, and when the scaphoid fractures, it fractures at the waist or the middle 1/3. That is why the distal area from where the blood supply comes, that stays vascular, but the proximal pole of scaphoid is known for undergoing avascular necrosis. I also want to tell you one more thing. Although waist is the commonest area where the fractures of the scaphoid occurs, but in the pediatric population, the distal pole injury is very common in scaphoid injuries. So distal pole in pediatric areas, waist overall the commonest in scaphoid. Then we come to the fractures of the base of the first metacarpal. One of the two varieties, Bennett's and Rolando, this is The differentiation point is that Bennett's is a fracture involving the base along with the pull of a muscle called as abductor pollicis longus. There is a dislocation. So Bennett's is a fracture of a base, but because it involves the base, that's why the fracture is always going to be intra-articular. This is an important point. Bennett's and one of the counterparts, Rolando, both are intra-articular. This is an important point for you to remember. But the difference is Bennett's associated with dislocation. One more thing, Bennett's is a very common fracture that takes place in the boxers. Remember this point, we'll have a word about this again. So, very common fracture in boxers is Bennett's. When I look at its counterpart that I'm telling you, Rolando. Rolando is a fracture again involving the base, and it's also intra-articular, but there is no displacement. When I started reading, this is what I read in one of the books, that Rolando is extra-articular fracture. At that time, there used to be a soccer star called as Ronaldo. I made a mnemonic. Ronaldo is an extraordinary player. Rolando is an extra-articular fracture. And I just thought this was a great mnemonic. I went around my college in Mamsi and told all my batchmate seniors that this is a mnemonic I made, and they just appreciated the same. Right? Then we went for all India exam. We got this MCQ. In Delhi PG, the question got repeated. And everybody really appreciated the mnemonic that I made, right? Was coming so frequently. I didn't clear it my first go, and when I started studying, this is what I realized. I started referring to the books, and this is what I saw, that in the book it was written that Rolando is an intra-articular fracture. It's not extra-articular because it's involving the base. Thus, my mnemonic was not correct. And what do we learn from this? When you are preparing, be quiet, because there's an old saying, wise is quiet, fool is loud. Right? Focus on your studies. Verify whatever you're doing. Think why a question is coming again and again. There has to be a reason. Then we come to the next injury, which I expect can be another image apart from the chauffeurs. Boxer's fracture. Boxer's fracture is also called as the street fighter's fracture. Street fighters or boxer's fracture involves the neck of the fifth metacarpal. This fracture involving the neck of the fifth metacarpal is a common injury in boxers. So if they ask you, mind you, they ask you the most common injury in boxers, the answer is boxer's fracture. If they ask you most common injury in the boxers and the boxer's fracture is not the option, then you will choose Bennett's. But if it's an option, it happens to be the most common injury. And then, thank you very much for your patient hearing. Thank you very much. Happy learning, happy listening. I'll be releasing soon the fracture types involving the spine, the pelvis, and the lower limb. Kindly subscribe to Med Miracle so that you can get all the updates. Thank you very much. All the best.